Good morning, everyone, and thank you for being here today. I'm excited to share my MSc thesis with you. The title of my work is Validation of Nutrition Risk Screening 2002 Tool on Adult Patients Admitted at Leku Hospital in Shebedino District, Sidama Region, Ethiopia. Today, I will walk you through the motivation behind this study, the methodology I used, key findings, and the implications of this research. I look forward to your insights and questions at the end. Let's get started. Welcome to this part of the presentation where I will outline what we will cover today. First, we'll start with an introduction to the study, giving you some background and context. Then, I'll walk you through the objectives of our research, what we aim to discover or understand. Next, we'll look at the methods and materials we use to gather our data, which is crucial for understanding the reliability of our findings. After that, we'll discuss the results and what they mean, highlighting key insights. We will also examine the strengths and limitations of our study to provide a balanced perspective. Following that, I'll share our conclusions and some recommendations based on what we've learned. Lastly, I want to acknowledge everyone who contributed to this work. This outline will help guide us through the presentation smoothly and ensure we cover all important aspects comprehensively. Let's talk about undernutrition. Essentially, it involves changes in body composition, particularly a reduction in fat-free mass and body cell mass. This decline can really diminish both physical and mental functions, making recovery from illness more difficult and affecting overall outcomes. Undernutrition typically results from not getting enough nutrition in the first place. That could be due to a lack of dietary intake, meaning we're not consuming enough nutrients. It can also happen through excessive nutrient loss, which might occur with certain illnesses or conditions that cause nutrients to be lost more rapidly. Additionally, sometimes the body's requirements for nutrients increase, like during healing or growth, and if those needs aren't met, undernutrition can develop. Often, it's a combination of these factors, insufficient intake, increased losses, and higher requirements, that lead to this condition. Understanding these underlying causes is crucial, because addressing them effectively depends on identifying which of these factors is playing the biggest role in each individual case. This sets the stage for better management and intervention strategies. Patients can develop undernutrition either before they are admitted to the hospital or during their stay. It's actually quite common. Studies show that anywhere from 20 to 78% of hospitalized patients are undernourished. This is a significant issue because undernutrition is not just a nutritional concern, it's a predictor of poor patient outcomes. For example, patients who are undernourished tend to have higher mortality rates, especially when infections are involved. It can also lead to longer hospital stays, sometimes increasing the duration by 40 to 70%. That's a huge impact on both the patient's recovery process and hospital resources. And speaking of resources, undernutrition also drives up healthcare costs. When patients stay longer or experience complications, the financial burden on healthcare systems increases. So, as we continue with this presentation, keep in mind how crucial it is to identify and address undernutrition early. Doing so can really improve outcomes and help manage costs more effectively. Today, I want to emphasize that nutrition screening at the hospital is strongly recommended for all adult patients. One of the most widely used tools for this purpose is the NRS 2002, which was developed by Kondrup and colleagues in 2003. It's important because using a proper screening method helps us identify patients who are at risk of malnutrition early on. But for the screening to be effective, we need a valid and reliable tool. While NRS 2002 is recognized as a valid screening instrument, it's worth noting that it has not yet been validated specifically within the Ethiopian context. That's a gap we aim to address with our current study. We validated the NRS 2002 here, which is a crucial step because it ensures the tool accurately reflects the nutritional status of our patients in this setting. So, in summary, even though NRS 2002 is a proven tool globally, validating it locally makes it even more reliable for our patients. This is essential to improve our nutritional assessment practices and ultimately enhance patient care across our hospitals. Today, I will be discussing the general objective of our study, which is to validate the nutrition risk screening tool, specifically the NRS 2002, for adult patients admitted to Leku Hospital in the Sidama region of Ethiopia in 2022. The main goal here is to see how well this screening tool works in identifying patients at risk of malnutrition. We also have several specific objectives. First, we want to assess the prevalence of risk for undernutrition among these patients. This means determining how many patients are at risk based on the screening results. Second, we aim to evaluate the prevalence of undernutrition itself, which involves looking at how many patients are actually undernourished. And third, our goal is to validate the NRS 2002 as an effective tool for screening the risk of undernutrition. Essentially, we are checking whether this tool accurately identifies those who are at risk, so we can improve early detection and intervention. All of these objectives are central to our overall aim of improving nutritional assessment and patient care in this setting, ensuring that we use reliable tools to support our clinical decisions. Now, let's take a closer look at the study area. Leku Hospital is one of the 21 hospitals serving the Sidama region. This setting provides a diverse patient population, which is essential for the kind of research we're discussing. Moving on to the study design and period, we adopted an institution-based cross-sectional study approach. This means we looked at data from a specific point in time, or over a defined period, which in our case was from October 2021 to February 2022. This timeframe allowed us to gather relevant data within a 6-month window, providing a snapshot of patient characteristics and outcomes during that period. Regarding the source and study population, we focused on all adult patients who were admitted to the hospital over the course of a year. More specifically, our study included every adult admitted during the entire study period. This broad inclusion helps ensure that our findings are representative of the adult inpatient population at Leku Hospital. Finally, when it comes to materials and methods, I want to emphasize that the details, such as data collection tools, procedures, and analysis techniques, are critical to the integrity of the study. Although I haven't listed all the specifics here, they are designed to ensure accurate and reliable results, which will support the overall research objectives. This comprehensive approach helps us understand the health issues faced by adult patients in this region and contributes to improving healthcare strategies. Now, let's look at the inclusion and exclusion criteria for our study. For inclusion, we're focusing on adult patients, meaning those who are 18 years or older. This helps us narrow down our population to adults, which is important for consistency and relevance to our research questions. On the other hand, our exclusion criteria help us refine our sample further. We exclude pregnant women, as pregnancy can introduce additional variables that might affect our outcomes. We also exclude patients who are edematous or severely ill, because their condition could skew our results or make participation unsafe. Next, let's talk about how we determined our sample size. We calculated the required number of participants for each specific objective in our study. After doing these calculations, we chose the largest of these numbers to ensure we have enough power for all objectives. In this case, 310 was the largest sample size needed, and we calculated this using the single population proportion formula, which is a standard method for such determinations. Finally, this part connects to the overall methodology, ensuring that our sample is both appropriate and sufficient to support valid and reliable results. All right, let's take a closer look at the sampling procedures used in our study. We had a total of 310 participants, with 116 from the surgical ward and 194 from the medical ward, all at Leku Hospital. Now, to select our sample, we employed 2 different methods. First was purposive sampling, which means we intentionally chose specific participants based on certain criteria to ensure relevance to our study. The second was systematic sampling, where we selected every nth patient to maintain consistency and reduce bias. These methods helped us validate the NRS 2002 tool effectively across different patient groups within the hospital setting. Overall, combining these approaches strengthens the reliability of our findings and ensures diverse representation in our sample. Now, let's take a closer look at the data collection procedures and tools we used for this study. Data were collected during hospital admission, which allowed us to gather information at a critical point when patients were already in the healthcare setting. Before we started collecting data, we made sure to explain the purpose of the research clearly to all participants, ensuring they understood what we were doing and why. For measuring weight, we used a calibrated weight scale to ensure accuracy and consistency in our measurements. Height was obtained using a portable stadiometer, which is convenient for bedside assessments and provides reliable data. Moving on to data quality control, we placed a lot of emphasis on training our data collectors thoroughly. This step is crucial because well-trained collectors reduce errors and improve the reliability of the data. We also pre-tested the questionnaire, which helps identify any unclear questions or issues before the actual data collection begins. Throughout the process, data collection was supervised actively, allowing us to monitor quality and address any problems immediately. These steps, training, pre-testing, supervision, are all part of our commitment to maintaining high data quality, which is essential for the validity of our overall research findings. Now, moving on to the data analysis section, we applied several statistical tools to evaluate our results. Specifically, we used the chi-square test to examine associations between categorical variables and the ROC curve to assess the diagnostic performance of our model. The ROC curve is particularly useful because it helps us visualize the trade-off between sensitivity and specificity at different thresholds. We also implemented the Youden index, which is a simple but powerful way to identify the optimal cutoff point. The formula is yi equals sensitivity plus specificity minus 1, and it essentially helps us find the point where our test best balances true positive rate and true negative rate. Shifting gears to ethical considerations, I want to highlight that we obtained ethical clearance from the Institutional Review Board, or IRB, to ensure our study met all ethical standards. We also secured a permission letter from Leku Hospital, which is crucial for access and cooperation. In addition, informed consent was obtained from all patients participating in the study, ensuring they understood what the study involved and agreed to take part. To maintain confidentiality, all patient information was anonymized by assigning codes, which helps protect their privacy throughout the research process. And finally, as we continue with the materials and methods, I'll provide further details on the specific procedures and tools we used to carry out this study. Let's take a closer look at the socio-demographic characteristics of our respondents. First, out of the total, 181, which is about 58.4%, were male patients. This indicates a slight predominance of males in our study group. Next, about 1/3 of the participants, precisely 33.2%, were in the older age group, meaning they were 60 years or older. This highlights the significance of age in our sample, especially when considering health outcomes. Moving on, the majority of participants, nearly 63%, came from rural areas, which underscores the rural context of our study population. Finally, more than half of the respondents, 57.4%, did not have formal education. This is an important factor because education levels can influence health awareness and access to healthcare. Overall, these socio-demographic details help us understand the background of our participants and are essential for interpreting the study results within the right context. Let's take a closer look at the socio-demographic characteristics of the 310 adult patients admitted to the medical and surgical wards. Starting with gender, we see that the majority are male, making up about 58.4%, while females constitute 41.6%. This suggests a slightly higher representation of males in our patient population. Moving on to educational status, more than half of the patients, around 57.4%, have no formal education. This is quite significant and may reflect broader educational disparities in the community. The remaining patients have varied levels of education, with about 24.9% having primary education, 9% with secondary, and 8.7% holding a diploma or higher. When we look at occupational status, half of the patients, or 50%, are farmers. This indicates that a large portion of our patients are engaged in agriculture, which could be relevant to their health profiles and access to health care. Other occupations include merchants at 15.5%, government employees at 9%, students at 11.3%, and a smaller percentage, about 7.1%, are unemployed or belong to other categories. Regarding the area of residence, most patients, about 62.9%, live in rural areas, with the remaining 37.1% residing in urban settings. This rural predominance might influence factors like access to healthcare services and health literacy. Finally, considering age distribution, the patients span across different age groups. The largest segment, roughly 33.2%, are older adults aged 60 and above. Young adults aged 18 to 25 years make up 15.2%, while adults aged 26 to 44 are about 31.3%, and middle-aged individuals between 45 and 59 years comprise 20.3%. Overall, this table provides a comprehensive snapshot of our patient population, highlighting key socio-demographic factors that can influence health outcomes. Understanding these characteristics helps us tailor our approaches and interventions more effectively. Now, moving on to the next point, we see the prevalence of risk for undernutrition among adult patients admitted to Leku Hospital. As shown here, approximately 50.6% of these patients are at risk, which is quite significant. On the other hand, about 49.4% are not considered at risk. These figures highlight that nearly half of the patients could be vulnerable to nutritional issues, which can greatly impact their recovery and overall health outcomes. This data underscores the importance of early detection and intervention for undernutrition in hospital settings. It also ties into our broader discussion about the critical role nutrition plays in patient care. Recognizing and addressing these risks promptly can improve patient recovery rates and reduce complications. So, this slide essentially reminds us of the substantial proportion of patients at risk, emphasizing the need for routine nutritional screening and targeted support in hospitals like Leku. The risk for undernutrition prevalence in our study was found to be 50.6%. This figure is quite similar to what was observed in 3 South African hospitals, where the prevalence was about 53.7%, according to Blau and colleagues in 2019. However, when we compare this to a study done in Poland, specifically among nephrology ward patients, the prevalence was lower, at around 41%, as reported by Borek et al. In 2017. This difference could be largely explained by socioeconomic factors, which tend to influence nutritional status significantly. So overall, these findings highlight that undernutrition is a substantial concern across different settings, but the prevalence can vary depending on socioeconomic contexts and healthcare environments. Understanding these differences helps us tailor interventions more effectively and recognize the broader social determinants at play in nutrition risk. The prevalence of risk for undernutrition in our study appears to be relatively low when we compare it to some other studies conducted in the region. For instance, a study from South Africa reported a prevalence of 72.3%, and in Zambia, it was around 59.7%. These figures are notably higher than what we've observed here. Now, these differences could be explained by a few factors. One key aspect is the screening tools used in these various studies. Different tools can yield different results, as Raslin and colleagues highlighted in 2010. Additionally, sample size variations between studies can also influence these prevalence rates. So, when interpreting our findings, it's important to consider these methodological differences. They help us understand why our results might differ from those regions and emphasize the importance of standardization in screening methods. This discussion ties back to the overall theme of our presentation, which is understanding the risk factors and prevalence of undernutrition. Recognizing these differences helps us better target interventions and improve screening practices across different settings. Let's take a look at the prevalence of undernutrition among the adult patients admitted to Leku Hospital. As you can see here, about 37.1% of these patients are affected by undernutrition. That's more than a third, which is quite significant. On the other hand, 62.9% are not undernourished, indicating a better nutritional status among a majority of patients. This figure really highlights the importance of nutritional assessment and intervention as part of the overall patient care. It also underscores how prevalent undernutrition is in this setting, which can impact recovery times and overall health outcomes. By understanding these numbers, we can better tailor our approaches to improve patient nutrition and, ultimately, their recovery process. This data connects to our broader theme of addressing malnutrition as a critical component of healthcare improvement. Recognizing the high prevalence here helps us focus on targeted strategies to combat undernutrition effectively. On this slide, we're continuing to look at the prevalence of undernutrition among our study subjects. We found that 44 individuals, which is about 14.2%, had a BMI less than 18.5 kg per square meter. This indicates a significant portion of our population is underweight according to BMI standards. Additionally, 114 participants, or roughly 36.8%, were undernourished based on MUAC measurements. Specifically, MUAC less than 22 centimeters for females or less than 23 centimeters for males. When you combine these figures, you see that a total of 37.1% of the patients were undernourished, either by BMI criteria or MUAC criteria. This highlights how prevalent undernutrition is in our study group, which is a key concern when addressing overall health and treatment outcomes. Understanding these numbers helps us grasp the extent of nutritional issues and guides us toward targeted interventions. So overall, these results emphasize the importance of screening for undernutrition using multiple measures to get a comprehensive picture. Now, looking at the prevalence of undernutrition, we see that it's relatively high in our study compared to some other regions. For instance, studies conducted in China reported prevalence rates around 20.41% and 22%, as noted by Liu and colleagues in 2021 and Kang et al. In 2018. These differences might be due to variations in the study, participants themselves, or socioeconomic factors that differ from one country to another. On the other hand, when we compare our findings to studies from Ethiopia, the prevalence is actually lower. For example, Amer et al. In 2015 reported a rate of 77.8%, and Hale et al. In 2015 found 55.6%. The significant difference here could be explained by the nature of the study areas, whether they focused on referral hospitals or general hospitals, which can influence the prevalence rates we observe. Overall, these comparisons highlight how contextual factors, including socioeconomic status and the specific populations studied, play crucial roles in the prevalence of undernutrition. Understanding these nuances helps us better interpret our findings within the broader research landscape. Let's take a closer look at this table, which explores the association between 4 key questions and undernutrition. Starting with the first question, is BMI less than 20.5 kg/m2? Here, we see that a significant proportion, about 62% of those classified as undernourished answered yes, compared to only 19.8% of those not undernourished. The chi-square value is quite high at 53.053, and the p-value is less than 0.001, indicating a strong statistical significance. This suggests that a low BMI is strongly associated with undernutrition. Moving on to the second question, has the patient lost weight? We see an even more striking difference. Among undernourished patients, 84.1% reported weight loss, whereas only 23.7% of those not undernourished did. The chi-square here is 83.881, also with a p-value less than 0.001, reinforcing the idea that recent weight loss is a critical indicator of undernutrition. The third question asks, reduced food intake. Again, there's a significant association. Over half of the undernourished group, 55.4%, reported reduced intake, compared to just 23.9% in the well-nourished group. The chi-square is 32.088, with a p-value less than 0.001, confirming this is a meaningful predictor. Now the fourth question, is the patient severely ill? Interestingly, the difference here isn't statistically significant. The chi-square is only 0.086, with a p-value of 0.769. This suggests that, unlike the other questions, the severity of illness alone may not be as strongly linked to undernutrition in this context. Overall, these findings validate that questions about BMI, recent weight loss, and reduced food intake are strongly associated with undernutrition. This underscores the importance of these factors in screening and early identification. It also highlights how crucial it is to consider multiple indicators together when assessing a patient's nutritional risk, especially as part of a comprehensive screening process like NRS 2002. Let's take a closer look at the validation of the initial screening part of NRS 2002. As we discussed earlier, this screening is crucial in identifying patients at risk of undernutrition early on. Now, focusing on 3 key questions within this screening, we found that they were significantly associated with undernutrition. First, BMI, or body mass index. Specifically, a BMI less than 20.5 was strongly linked to undernutrition, which is supported by the study from Borek et al. This makes sense because a lower BMI often indicates underweight status or poor nutritional reserves. Next, we have weight loss. Significant weight loss in patients is another critical indicator of undernutrition, and this association has been supported by research from Hale and colleagues in 2015, as well as Savadogo et al. In 2019. Consistent weight loss can be a sign that nutritional intake isn't meeting the body's needs, which can compromise recovery and overall health. Finally, reduced food intake was also associated with undernutrition. A study by Allard and his team in 2015 highlighted that when patients experience a decline in their food consumption, their risk of undernutrition increases. Putting it all together, these 3 questions, BMI, weight loss, and reduced food intake, are not just simple screening tools. They are validated indicators that help us identify at-risk patients early, allowing for timely intervention. This is a key part of our overall effort to improve patient outcomes through effective nutritional assessment and management. Now, let's take a closer look at the validation of the final screening part of the NRS 2002. The area under the curve, or AUC, is 0.768. This indicates a good level of accuracy in distinguishing between those who are at risk and those who are not. The sensitivity, or SN, is 83.5%, meaning the test correctly identifies a high percentage of true positives. On the other hand, the specificity, or SB, is 68.7%, which shows a moderate ability to correctly identify true negatives. This figure, Figure 4, compares the AUC of the NRS 2002 with a combined assessment of BMI and MUAC. Overall, these results suggest that the NRS 2002 performs quite well in validation, but also highlight the importance of combining different assessment tools for a more comprehensive screening. This aligns with our overall goal of improving nutritional risk screening accuracy. Let's take a closer look at Youden's index, which is calculated as sensitivity plus specificity minus 1, a formula introduced by Youden in 1950. This index helps us identify the optimal cutoff point for a diagnostic test by balancing sensitivity and specificity. In our analysis, 3 was determined to be the best cutoff point for NRS 2002. Looking at the table, you can see that at this cutoff, the sensitivity is 83.5%, and the specificity is 68.7%. The Youden's index here is 0.522, which is the highest among all the cutoff points listed, indicating it provides the best overall balance between correctly identifying those with undernutrition and those without. This cutoff point is particularly important because it maximizes the test's accuracy in our context. The AUC, or area under the curve, is 0.768 with a confidence interval from 0.713 to 0.822, and a p-value less than 0.001, which confirms that the test performs significantly better than chance. So, in summary, choosing 3 as the cutoff point for NRS 2002 allows us to effectively identify undernutrition, balancing the true positive and true negative rates, and improving our screening accuracy overall. This is a key step in ensuring we accurately detect those who need nutritional intervention. Let's continue by looking at the validation of the final screening part of NRS 2002. We found that the NRS 2002 has a fair level of accuracy, with an area under the curve of 0.768. This suggests it's reasonably good at predicting outcomes, but not perfect. A study conducted in Brazil further supports this, showing that the NRS 2002 can fairly predict mortality, specifically the risk of death. This was detailed in the research by Raslin and colleagues in 2010. Additionally, the NRS 2002 also demonstrated a fair ability to predict non-infectious complications, which is a key aspect when assessing patient risk and planning interventions. This was highlighted in a study by Wang and colleagues in 2016. Overall, these findings reinforce that while the NRS 2002 isn't flawless, it remains a useful tool in identifying patients at risk for adverse outcomes, linking directly to our broader theme of effective nutritional screening and risk assessment. All right, let's start with the strengths. This study is actually the first one conducted in this particular study area, which makes it quite significant because it provides new insights specific to this population. Being the first also means we're laying the groundwork for future research here. Now, moving on to the limitations. One of the main constraints was that we used only BMI and MUAC measures as our gold standard. While these are commonly used indicators, they do have their limitations and might not capture the full complexity of nutritional status. Additionally, we didn't take exact weight loss measures, which could have provided more precise data on changes over time. That's something to consider for future studies to improve accuracy. Another point is that our sample didn't include multiple centers. It was limited to a specific area. So, while our findings are valuable, they might not be fully generalizable across different regions or populations. Overall, recognizing these strengths and limitations helps us understand the context of our findings and guides us on how to refine our approach in future research. In conclusion, when we look at BMI, a value less than 20.5 kilograms per square meter suggests that the patient may have lost weight and possibly reduced their food intake. These are the 3 initial questions we consider during pre-screening to assess nutritional risk. We also found that 3 is the optimal cutoff point for the NRS 2002 tool, meaning that if a patient scores 3 or higher, they are at an increased risk for undernutrition. It's important to remember that while NRS 2002 demonstrated fair accuracy, it's a useful screening tool, but not perfect. Overall, these findings help us refine our approach to identifying patients at risk, ensuring we intervene early and appropriately. It's all about being proactive in managing nutrition and supporting patient health effectively. So, moving on to our recommendations. First, we suggest that the Ministry of Health consider implementing a policy for nutrition risk screening across healthcare facilities. This is a crucial step in identifying patients who may be at risk of malnutrition early on. By doing so, we can improve patient outcomes and streamline nutritional interventions. Next, specifically at Leku Hospital, we recommend adopting the NRS 2002 as the standard screening tool. It's a validated and reliable method that can effectively help healthcare providers assess nutritional risk in their patients. Additionally, to ensure that the NRS 2002 is truly suitable and effective in our local context, we strongly suggest conducting a multi-center prospective observational study. This will help us gather solid evidence to validate its use and adapt it if necessary. In conclusion, these recommendations aim to strengthen our nutritional screening processes, ultimately contributing to better patient care. Implementing these steps aligns with our overall goal of improving health outcomes through better nutrition management. First of all, I want to acknowledge the Almighty God for providing me with the strength and guidance throughout this journey. I also want to express my gratitude to Hawassa University College of Agriculture, specifically the School of Nutrition, Food Science, and Technology, for supporting this research. I am deeply thankful to my advisor, Dr. Alemne Kabata, whose guidance and expertise have been invaluable in shaping this work. I must also recognize the study participants and data collectors, without whom this research wouldn't have been possible. Their cooperation and effort made it possible to gather the essential data needed for this study. Additionally, I want to thank my family for their unwavering support and encouragement, which kept me motivated during challenging times. Finally, I would like to extend my heartfelt thanks to everyone who contributed in any way to making this research a success. Thank you for joining me today. I truly appreciate your time and attention throughout this presentation. I hope you found the insights and information valuable and applicable to your work. Remember, the key points we've discussed highlight the importance of understanding the core concepts and how they connect to the bigger picture. It's all about applying these ideas effectively to make a positive impact. Once again, thank you so much for being part of this session. I look forward to seeing how you take these concepts forward.